Don't go away very far. I'm going to invite all of the speakers to come up onto the stage just now. There are two more chairs there, so if you can draw them all in. We have chairs for all 6 of you. And I'm going to open this out for a discussion, and I really am encouraging now the bedside nurses, the fellows, dietitians. You guys have been a little quiet. I want to hear a little bit more questions from you all. Because here's your opportunity. You don't get a chance better than this to have essentially the world experts on this subject here in front of you, and also just the very practical questions of you know, how should we best diagnose this? What are the risk factors? You've seen in the last few weeks the number of cases we've had of NEC. Did we miss something? Should we have caught something? Should we diagnose this differently? What studies could we do? And when should we be consulting? What's the threshold to consult? These are the sorts of questions that I know I've heard when I'm in the unit, and maybe now's the opportunity to ask those questions. Don't all get up at once.
Actually got 2 questions. One of them relates to the incidence of spontaneous perfs and neck, surgical neck, and the high incidence of retrieval of CMV from those patients or the tissue samples. Seeing as a lot of the outcomes are catastrophic, would it make sense to check the patients as they come into the unit for CMV? That's the first one. You can entertain that one first, I guess.
So we have not been routinely checking babies for CMV. I know about the reports of this association. A lot of our babies who have putative perforations get just drains placed rather than having laparotomies done. And a lot of the babies do not have some of the other signs of CMV. So we haven't been chasing that down very aggressively. So maybe it's something that we should be doing more aggressively, but we have not been doing that.
Okay.
We check salivary saliva initially as far as CMV, but the one case I remember of a baby with NEC who also had CMV that we found when the baby developed some liver failure, this was an acquired thing. Okay. So that's a piece that you have to be aware of as well.
Sure. And my second question has to do with probiotics. It seems like all of the products that are available on the market either 1 or 2 strains, and yet it appears that diversity of gut or GI microbiome seems to be protective. The 2 don't seem to match using 1 or 2 strains to try and address the microbiome.
This is kind of a potentially long story, and I'll try to make it short. The products that are available and what we're doing in neonatal intensive care without having the right kind of studies that have gone through true phase 1, phase 2, phase 3 studies, we are using them as a food and not as a pharmaceutical agent. But if you go by the definition of the European regulatory agencies and the FDA, you should be using them as a pharmaceutical agent, and that means that they have to have the phase 1, phase 2, phase 3 kinds of studies. Those have not been done, okay? The products that are available, some of them have been looked at very closely using PCR techniques, using culture-based techniques, and what they say is in there is not what you get. There have been cases, I think the most famous one is the one at Yale University where the baby died after use of a probiotic, and the baby developed mucormycosis with a ABC Dophilus preparation, and that was contaminated, putatively contaminated with mucormycosis. So I think that we have to be very careful with the products that we're using and how we're using it. And I like the idea that we need to regulate those.
And it wasn't done in babies, but there was a large study in the Netherlands in adults using probiotics for necrotizing pancreatitis. And they were thinking, well, this is just going to be beneficial and not harmful. But actually found that the ones that were treated with probiotics were dying a lot more. So the trial was stopped. And I think it's important to know what you're doing while you're doing these things. So it sounds like a great idea, and it sounded like a great idea, but that was actually harmful to the patients.
But that would partly been the timing of it. The treatment was started after the patients developed the condition.
Yeah.
Two things in Canada as well. It's probiotics are under nutraceuticals, so they're not health protection branch authorized, and so they don't have to go through regulation. There can be a study that looks at Flora Baby, for example, which we use in BC and is used a lot in Canada. But that was, at the time of that study, that was the component parts of it. But there's no regulation that you're sure that now or tomorrow it's going to be the same. So you have no idea what you're giving. So that's a problem. I just to reassure you in terms of probiotics, I would not recommend that for any. We are not recommending it for babies with intestinal failure who have leaky guts, that they get probiotics.
Can we add on to that question? Is how do you balance the risk of using the probiotics as well in many of these patients who have central lines?
Okay, yeah, to my knowledge, I don't think that we've seen a lot of associated problems with the central lines and the probiotic use, although we haven't looked for it either. You know, so it may very well be that some of these kids who are at very high risk do have translocation, and they may be seeding into the central lines, and we just haven't studied it.
Because I think the evidence is not great, but in the older children, for example, any of our kids who are on TPN, sort of the children are outpatients, they're forbidden from having probiotics just because of the higher risk of infection. And a lot of our neonates end up with a PICC line or some sort of central line because they need long-term good access.
Yeah, this is maybe a question for Richard. Did you look at the use of CRP to determine when to reintroduce or restart feeds after NEC?
No, there was no, not that I remember. They looked at what came up in that stricture formation. But no, that wasn't part of the findings.
Sorry, I want to ask a few short questions, if you will allow me. First of them, as we know, the necrotizing is almost one of the very limited list of the diseases which you cannot say we should give this for the patient. Once we diagnose the disease, we don't have any medication. For example, we don't have anything like the hyaline membrane disease or PPHN or whatever. We have some specific things to give to the patient. That's why I'm still so occupied with the researches which is going to check the availability of any medications which can decrease either the incidence or the risk factors or even to manage it. So my question is if there is any kind of progress in this field, for example, the toll-like receptor inhibitors. I read about two couples of studies are going in this field, the platelet activator factor inhibitors. If there is any advances in this field or there is any near hope we can see about it?
So I know that David Hackham has the TLR4 receptor antagonist that he's working on. I think that they have, I don't know if it's patented yet or if they have applied for a patent. And I know that they're working with the regulatory agencies to try to get some studies going with that. In terms of just, this is opinion, okay? I'm not sure if one component of the pathway and inhibiting one component of the pathway, albeit it may be a very important one, is going to be the panacea for necrotizing enterocolitis. You're talking about giving this not to babies who just develop the symptoms, but you're probably talking about giving this to all babies. So that's going to be a real potential issue, and it's going to be very difficult to get it through the regulatory agencies, number one, and then number two, they're going to have a study. And if you get to the point of a study that looks at efficacy, you're talking about 1,500 plus babies to be able to adequately study that. So that's an uphill climb. Same thing with the PAF. I think that Mickey Kaplan and group have given up on the PAF inhibitor part.
I think we've had like probably 20, 30 years now where there were a lot of one gene diseases that were discovered, and then they said, well, this is the gene that's causing the disease. We can try and fix the gene, or we can try and address the one thing that's wrong with this disease with medication or something like that. I think a lot of the things in pediatric surgery, congenital anomalies, and in necrotizing enterocolitis, this is just a part of it. There's probably the environment. There's all kinds of things that play into developing neck in a baby. And I think the next 20 to 30 years is probably, hopefully, going to find some of these causes where it's not just one gene, but it might be the toll-like receptor interacting with something that we don't know yet in the environment or in the unit or in the doctor or the nurse that's taking care of it, or the mother or the father. And I think we are getting closer to being able to tackle some of these questions. But I would agree, I don't think it's one piece that's going to be, it's going to be probably a panel of things or a profile that we'd have to address.
And this will guide me for the second question very quickly, if you allow me. What are the most suggested research fields which you can advise the fellows like us to go through this amount in this coming few years?
I like to answer that. So as I said, just as a follow-up, I think we're going to get close to where you have a baby with a disease, and we're going to be able to take into account everything the baby is affected by, right? And it could even be the weather outside or the amount of light that's in the unit, because we're going to have access to so much data, and we're going to have the systems to analyze that data and understand the data. And they're doing that with IBM Watson and like the artificial intelligence. And I think if you are smart, you want to learn how to include artificial intelligence into analyzing some of these research diseases. Because I think that's where a lot of the answers are going to come from. I don't think we're going to be able to clone the neck gene or something. I think we're going to have to mine large data sets, analyze that, and then recognize patterns, which we're not able to do as humans yet, I think, but that's where artificial intelligence might help.
Thank you.
Can I just add, and I agree with you, I think that we still have to go back and figure out what is NAC. We don't have a definition for it, so we have to start there, and then also, as a neonatologist, I would love to have something better than CRP. CRP is antiquated, and yet that's all we are using. There are better tests that we can do, and that should be very quickly available to us, so we don't start antibiotics wholesale on everyone.
And you would be able to tell me this is neck with a perforation, or no, this
No,
is
that's
spontaneous intestinal perforation as a complete different entity, and we might have to address that differently.
Yeah, absolutely. There are all these different entities that were mentioned earlier.
So like I have a related question. Once you have like a radiologic diagnosis of neck and you do like cultural stunt antibiotics, would you consider to complete the antibiotics up to like during the entire period of MPO, even if you have negative culture, no evidence of bacteremia?
Maybe we don't need it.
Yeah, that's so. Because we're still doing the
And
same
I
practice.
think Richard actually brought this up in his lecture, and I kind of looked at that. The evidence for using antibiotics
Yeah.
in a suspected episode of NEC, we don't have,
Exactly.
you know,
Unless we have
the evidence to support the use. But I can tell you, just recently I reviewed a legal case of a neonatologist who stopped the antibiotics too early or supposedly stopped antibiotics too early, and the baby ended up progressing in the necrotizing enterocolitis. It may not have had anything to do with the antibiotics at all.
Yeah.
But I think that this is our concept, this is our dogma right now, and if you stray beyond that without having evidence on the other side, I think we may be in trouble. And we have to get that evidence on the other side. How are we going to do that? That's going to be another challenge.
Yeah.
Yeah. Thank you very much to all of you. I have 2 points. So one is to Dr. New, and you were talking about a biomarker for NEC that we might do a study which includes all the preterm babies, and then we could find something like Claudin 13 that would predict whether a baby develops NEC or not. So let's say we find something like that and we could predict it 10 days before it happens. What would we change to prevent it? And then my second point is there's a group in Toronto and they study remote ischemic conditioning as a potential treatment for NEC. I don't know if you heard about it, and maybe you could comment on that, but basically what they do is they put a limb into ischemia for like 3 to 4 minutes, and then the body releases anti-inflammatory factors, and it not only could prevent the NEC, but they could also reverse it in mice studies. So that could be maybe a potential treatment instead of just preventing it.
Okay, so number one, the mouse studies and what you're talking about there, the pertinence of rodent studies to human necrotizing enterocolitis, I think is still a stretch. And so I have to say, I'm not going to totally poo-poo those studies, but I'm a little bit skeptical because the rodent model is not the same thing as what we see in humans. Your first question had to do with some of the biomarkers, the claudins, the intestinal fatty acid binding proteins, and it is possible that if the study is done correctly, that we might be able to see those being elevated well before the development of symptoms. So then what do? I don't know. I think that to have a higher index of suspicion in those babies, and then when something begins to happen to those babies, I would probably consider looking more closely, using ultrasounds, using some of the other techniques that we have to see if we can diagnose this, then being very careful with the kinds of food that we're giving to the babies, maybe not advancing feedings quite as rapidly. I don't have the answer to that, but I think that it still would be valuable to have those biomarkers, the predictive biomarkers.
I have a comment like with the, we believe here in Winnipeg the idea of integration. So we have a limitation from the X-ray. You consider the X-ray as maybe the routine check because we don't have enough a team in Canada to do ultrasound as a routine, like in these cases. So having the ultrasound as adjuvant, the biomarkers, the clinical impression. So the idea of integration and point of care, it's having a neonatologist who is available in the unit, who's able to integrate everything all together, who's understanding everything, is different from someone who's staying in the office reviewing just the image. So the biomarkers, whatever biomarkers available, there is a limitation like CRP or any other modality. So is in integration or using the adjuvant techniques together with the X-ray, with the clinical situation will make the picture more clear. The X-ray, when you mention about the sensitivity related to the question again for Ruben, from Ruben, that to evaluate the sensitivity for any modality, you have to have a gold standard, which we don't have in NEC. So we can't send every baby with neck for CT scan or MRI to compare whatever modality is available. So the availability now is just to integrate everything, make the picture more clear by someone who's understanding the clinical condition in more details. So that's the idea that we are implemented in Winnipeg for almost 3 years now, the integration. Having someone in the unit doing these techniques, not someone else from outside the unit.
One other point to your question, I think that what I mentioned before about interventions, early interventions for all babies, if you have not so much a diagnostic, but a predictive biomarker that puts the baby into a category of being at much higher risk, rather than having the need for 1,500 babies, 2,000 babies to do a interventional trial, you may only need 100 if you have that biomarker.
I think what I've learned today is that we are at the moment trying to prevent NEC. And we tend to use donated breast milk to start feeding these babies. My first question is, has someone looked at NEC in babies who were fed donated breast milk to breast milk itself? And my other question is, has there been any plan, or has someone thought of fortifying the DBM so that it is as close to breast milk as possible? And then the final question is, how effective can we get the drive going so that we don't have to limit the use of breast milk on our preterm babies?
Okay, so I'll try to answer some of those questions. I think you had 3 of them, and one of the questions was, have we ever looked at donor milk versus baby's own mother's milk? And the answer to that is no. No, we have not done a direct prospective randomized trial of that. I think that to do that is going to be it's not going to be easy. But in terms of donor milk, I think I mentioned before that it's not the same as the baby's own mother's milk. Donor milk in most places is pasteurized. Baby's own mother's milk in most places is not pasteurized. And with the pasteurization process, you lose alkaline phosphatase, lipase, the microbes, the cells. You lose a lot of really good stuff. And for us to have this concept that donor milk is the same as baby's own mother's milk is a big mistake. And you alluded to that before, that in our own unit, when the 2012 AAP guidelines came out for only using donor milk or baby's own mother's milk, we stopped using formula in babies less than 1,500 grams, but the concept came through to the nursing staff and to some of the mothers that donor milk is just as good as baby's own mother's milk. So we actually saw a decrease in the use of the baby's own mother's milk, similar to what you were describing. And I think that that's a potential mistake, and we have to stay away from having this concept that donor milk is the same thing. Are there some studies that have tried to make baby's own mother or donor milk similar to baby's own mother's milk? Well, one of the things is to utilize some enzymes, for example, recombinant lipase. There's been some studies on that. There's been some studies in animals looking at adding recombinant alkaline phosphatase, giving that. In our place, we've actually done some what are called transfaunation studies, where we take donor milk, and if the baby's own mother is able to make small amounts of her own milk, we take 10% solution or 1% solution of that baby's own mother's milk and put it into the donor milk, let it sit for 4 to 8 hours, and we can get a microbiome that looks almost exactly like the baby's own mother's milk. I don't recommend that you do that yet, but it is something that we sort of supported the concept of this refaunation so that we get a microbiome that looks like the baby's own mother's milk. If you let that sit too long, you start getting overgrowth of staph and other bacteria that could potentially be harmful. So I think studies need to be done on that before we, start doing that routinely.
As far as the nutritional composition, there are studies that have been underway, and we're doing a study looking at trying to use mother's own milk and adding additives, not just HMF, but trying to have some idea of what actually is in there using a Mirus analyzer to see exactly what's the protein, fat, et cetera. So those studies are underway to individualize nutritional value of milk that we're providing. I have a different question that I was going to ask you before. It seems that in some areas, particularly with the midwifery, that the whole microbiome is kind of ahead of us in trying to say, how do we recolonize babies? So if you've had a C-section, I've had a midwife running after us into the nursery, having swabbed the vagina and said, okay, put this on the baby, and we're all going, oh, yuck, this is a very sick little baby. Maybe they're right. What should we be thinking about in terms of that?
So the American College of OBGYN has actually strongly recommended against doing that practice until we get more data. I don't know how familiar you are with this, that there's a paper that was actually published in Nature Medicine, a very, very good journal, on 17 mother-baby pairs where they evaluated this technique, where the babies were born by cesarean section. A gauze pad was placed in the mother's vagina for an hour, and then that gauze pad, after C-section, was utilized to swab the baby's mouth, face, and the chest. And it was successful in terms of refaunating the baby's gastrointestinal tract with vaginal microbes. But what the American College of OBGYN is concerned about is that if that mom has unknown herpes or GBS or something else that could be nasty, you could actually be killing the baby. So you have to be very careful proceeding forward with that technique.
Hello, I'm Charla, one of the dietitians in the NICU. So we always promote mother's breast milk, and if we don't have that, we'll use the donor milk. But like Nana said, often we do use the donor milk first, because that's what we have before we can get mom's milk. We try to get the feed started as soon as possible. So we'll use the donor until mom's comes in. But then in patients who have neck or long-term gut difficulties, and we're having lots of troubles with feeds, and we've tried donor milk, or we've tried mother's milk, we're going up on feeds, we kind of do the bouncing up and down of getting them to tolerate the feeds. If mom's milk's not available, we'll use donor up to a certain point. And Susan, you had said you continue donor milk until they get to full feeds. Is there a point in time where you're trying mom's milk and it's just continually not working, that you would switch off of mom's milk and use a hydrolyzed product or a different type of formula?
Sometimes, excuse me, you might use half and half,
Okay.
or something that isn't just stop it completely, because there are a lot of advantages to mother's own milk. So again, I think you have to look at the anatomy. You have to look at what exactly is happening. I haven't completely thrown out concerns of bacterial, small bowel bacterial overgrowth. That may be an issue. I'm not a particularly strong proponent of the medication side of things. I don't think it's being useful at all in most of our babies. But occasionally it depends what the symptomatology is. But I think you can try some more broken down products, depending if you're having, you think that the carbohydrate isn't enough, or what exactly is happening in that situation.
Right. Okay. And then what other strategies do you use to promote mother's milk? Do you have a lactation consultant that you get involved? Or we've recently lost ours, but what other strategies do you have to get the moms to provide that milk? Any key tidbits that we can use as well?
can I tell you theoretical as opposed to what we're doing? Because we have exactly the same problem. All of our lactation consultants were off on maternity leave. It was a problem. We really, we would like to have lactation consultants in the nursery. We don't have enough of that, and we don't have enough promoting even labor delivery. This is where you have to start getting moms to start expressing. You have to talk about it. But people haven't, we need champions. So you can be the local champion. I mean,
I try.
You really have to have somebody who's really going to say, this is important, and you're going to do little educational sessions with the nurses, maybe labor and delivery. They'll be your allies to get it going. I think it's very basic, but if we don't do this, we're missing great opportunities.
Thank you.
We've come to the end of our morning and learned a hell of a lot. We've learned all the things we don't know. We've learned all the things that we could be doing. I think what I'm taking from this is if we're utilizing tools, we need to study them longitudinally to understand what those tools actually are showing us. We need to understand what our practices are and what we are recommending to do. Are we actually doing the things that we'd like to recommend? We have to understand the disease better from a pathological standpoint and a pathophysiological standpoint. We need better models of the disease. We need a model of the disease. We need to implement in feeding practices and refeeding practices a better understanding of nutrition, a better understanding of the mother-child dyad. We need to follow these children long-term and understand what implications having necrotizing enterocolitis has for a multitude of long-term outcomes that we don't necessarily associate with NEC. So what we have here is an incredible number of things that we still need to learn. And I open this up to our new neonatologists and budding neonatologists to develop this world, because if we don't do more research in this subject, we're going to feel about as humble 10 years from now as we feel right now. And with that, I'd like to really thank all of our speakers for coming to Winnipeg, opening our minds on this. Thank you all so very much.